Hello, everyone. We're going to give a couple of minutes for people to join us so that they'll be here for all of it. But we thank you for those of you who joined on time. Denise, I'm not sure how many people we estimate will be here. I traditionally am excited about things and try to start them early, but I'm going to wait another minute. Good. Okay, we will go ahead and get started. Thank you all for joining us for today's session of the CRISM Addiction Round series. Please note that the webinar is being recorded and will be posted on the CRISMPrairies.ca website. Denise usually sends the link to everyone who registered, so it should be easy to find later. I'm going to open the session with a territorial acknowledgement. The Canadian Research Initiative in Substance Matters has members from all across Turtle Island, the land now known as Canada. We acknowledge that Indigenous peoples are the traditional guardians of this land and respect the sovereignty, lands, histories, languages, knowledge systems, and cultures of First Nations, Métis, and Inuit nations. Ongoing criminalization, discrimination, and institutionalization of people who use drugs disproportionately harm Indigenous people. As such, we commit to ensuring this series is anti-racist and anti-colonial and serves as one of the ways to dismantle colonial structures that contribute to ongoing oppression. I just arrived back home yesterday from driving down to see my family in the States and was struck over and over again by the beauty of the land. We went through the foothills and over the Rockies and then through the prairies of Eastern Washington. And it was striking how much there is to protect here. If you have any questions during the session, please use the Q&A feature to send questions to the host and panelists. At any point during the session, I'll moderate questions after the presentation. We usually reserve about 15 minutes at the end for questions from the audience. And we value your feedback, so please complete the series evaluation, which you will receive by email after the session. Completion of the evaluation will allow you to request your certificate of attendance for your records also, as these are accredited. And now I'll introduce our speakers. Dr. Patrick McLane is a PhD sociologist. Through adjunct attachment to the Department of Emergency Medicine at the University of Alberta, he's developed a mixed methods research program examining inequity in healthcare and healthcare access. I have been, I don't know what the right word is, privileged, excited, something, to work with Patrick for probably about 15 years now. We met in AHS as both being researchers internally, and I can say that I have learned a lot from Patrick over the years, and I'm still incredibly honored to be involved with some of his projects, where I continue to learn a lot from him. So I'm really excited to have him presenting today. And with him is Dustin Walters, who's a health director of the Blackfoot Confederacy. And he is going to introduce himself with his Blackfoot name, as I was not able to learn how to pronounce it properly and don't want to mispronounce it. So if you'd like to introduce yourself some more, Dustin, I'd appreciate it.
Hey, okay, Nixokoayaks. Akit kanat samat samupua, ano kitsikoi. Anak ko ka, Dustin Walter. Kik nitsi sa pinskat sim six stakin. Ani duk sa tapi Ampskapii Pikunii. Hello, everyone. I'm happy to see everyone. I'm known as Dustin Walter, but my real name translates to Beaver Chief, and I am a Pikunii, Blackfoot Indian. So again, that's it.
Well, and I see that you might be from Montana.
Yeah, that's it. I said I'm from Ampskapii Pikunii, and I realized that that's not in English. I'm a South Peigan, which means I was actually born in Cardston, Alberta, in the Blood Hospital on a Gaina Reserve. But my hometown is Bab, Montana, and that's where I was raised on my reserve in just across the border. Our reserve ends at the border, as a matter of fact, and I did all my schooling there, K through 12 in uh, Indian day school. I did do some boarding school as well. And so I guess they call us survivors, but I just lived, and I went to residential school, and so I have some different viewpoints on how this all works, and I just like to remind everybody that I'm not a black and white photo. This didn't happen 200 years ago. I just turned 50. So we're still dealing with it today. My wife went as well to residential school. So we it might have predisposed us for a few things as far as addictive behaviors and things like that, but we've uh we've climbed out, and we're living our life, raising children in a clean and sober way. So I have a pretty expert opinion on addictive behaviors and treatment and all of these kind of different things. And that's a little bit of background on me. Get
Well, thank you very much. As someone else who has just turned 50, I appreciate that the reminder. Um, and so we will, Patrick, you're already sharing the slides. At least I assume you're sharing them. So we will let you jump in and tell us about the COVID-19 project that you ran.
Yeah. So our project was looking at interruptions to opioid use disorder care, specifically opioid agonist treatment around the COVID-19 disruptions. We were funded by the Canadian Institutes for Health Research to do that and approved to the University of Alberta Health Research Ethics Board. I'm really grateful to Dustin for coming along to present, as he's new to his role as health director, and really jumping into this project, presenting the results. I'm really grateful for that. For disclosures, so I was employed by Alberta Health Services through much of the conduct of the study. Now I'm at Acute Care Alberta. I've had research grants from CIHR, the Métis Nation of Alberta, and from Alberta Health Services. And I've had some expert opinion payments from a law firm and the Alberta Human Rights Tribunal. And Dustin, I believe you have no disclosures. Yeah.
Yeah, no disclosures that would conflict of interest.
Yeah. Right. So, so really privileged to do this work in partnership with Blackfoot Confederacy Tribal Council. Couldn't do this work in an ethical way without that partnership. But as Kay said, wanting to understand the impacts of COVID-19 disruptions and the opioid crisis for Indigenous people. Also have researchers at University of Alberta and University of Calgary. Alberta Health Services gave us a lot of support, and Acute Care Alberta, where I am now, continuing to support me. We have a large team. Bonnie Healy co-led the work and was former health director for Blackfoot Confederacy Tribal Council. Before that, as executive director at the Alberta First Nations Information Governance Center. She took a chance answering an email from a younger me, and is the reason I've been able to do work in the area of anti-racism. We also have, I won't go through everyone on the list, but Hiki Farani is an addiction physician who runs the Metro City Medical Clinic. Rhonda Rosachuk conducted all of our statistical analysis for this project, as she has for many projects I've been involved in. And we wanted to acknowledge staff at Blackfoot Confederacy Tribal Council, Natasha Scout, Travis Yellowings, and Buffy Bromley-Greer helped us organize gatherings to present results back to the Tribal Council and the health departments of the First Nations. Also, staff at the Biostatistics Consulting Group, my Equity and Emergency Care Research Program, and postdoc Mandy Gray helped us early on. Thankful to SPORE analysts, the Canadian Research Institute in Substance Misuse, AHS, and Alberta Health for helping us create the data set. So early in the pandemic, we were having reports of an upsurge in overdose-related ambulance responses and overdose deaths, and seeing media reports of closures in clinics or changing in how they operated, moving to virtual care. And so we knew at the time that First Nations were heavily impacted, and started talking to Bonnie and with Kay, who was on the team, and others. And we very quickly put together an application with a research grant to look into this. And I'll let Dustin speak to the next slide of the reason for Blackfoot Confederacy's interest.
Yeah, in the early portions of COVID-19, the Blackfoot Confederacy was struck by a lot of tragic overdoses. I believe we were up to like 90 in 5 days over a weekend in a long time, and over the weekend. And 90 is a huge number for our small population. So we were that placed Blackfoot Confederacy in a position where, as an entity that provides oversight and tries to help figure out problems about what's going on the in health and education, whatever division you're in, we really wanted to focus on, and we're excited about finding out what was going on here. And and as we all know, during COVID, during the pandemic, we had things, ER shutting down, there was no contact, we were all sheltering in place and things like that. So it made it particularly difficult, especially when we're in the face of interruptions in delivery of opioid-assisted therapy. And a lot of these instances, we found that according to the research, opioid-assisted therapy is kind of a cornerstone in improving mortality and morbidity in our populations of opioid-addicted users. And also another thing we were really looking at the time, none of our reserves had any kind of detox centers or drop-ins or emergency departments where they could go and procure their doses for the day. And so a lot of interesting research came out of this, and kind of hinting as to why we were in such dire straits as in relation to overdoses. So.
And so, yeah, as Dustin was saying, that the opioid agonist treatment is the preferred first-line treatment, involves opioid agonist, reduces morbidity and mortality. And we were concerned that with changes and sheltering in place, that there would be impacts on opioid agonist treatment. So we had 3 objectives for this study. Objective 1 was to look at, did the pandemic change who was being served in clinic and emergency department settings for OAT? And this was difficult to answer, and I'll get to that throughout the presentation. Objective 2, so to look at how First Nations members with opioid use disorder may have been differently impacted by COVID-19 disruptions to OAT. And the third, we're still looking at, so what would the implications of the research be for health system improvement? So the definition of an interruption for the purpose of this study, following literature, was greater than 6 days without any opioid agonist treatment dispensed. And we did count days that people were in the hospital as days where their OAT would be continued. We don't know if hospitals did, in all cases, keep people's opioid agonist treatment up, but gave the benefit of the doubt. And that we were recognizing that patients may have multiple interruptions during the study period. That study period was May 15th of 2019 to September 30th, 2020. And we considered the COVID period to be March 15th of 2020 to September 30th of 2020. And in comparisons, we'll be comparing it to the same period in 2019. And something really exciting about this data was that we were able to link data from multiple settings providing opioid agonist treatment. So Metro City Medical Clinics, which run independently of Alberta Health Services, Alberta Health Services opioid dependency clinics, and emergency departments, which we've done a lot of work in Alberta Health Services to have emergency departments able to offer buprenorphine naloxone. So any patients who receive medication in these settings is included in our data set. If patients initiated with their family doc or another OAT clinic, they are not included unless they subsequently received OAT in one of the three settings we were looking at. We are looking at Calgary and South Zone, largely for greater comparison to the Blackfoot Confederacy population. And we had 2495 patients receiving OAT in our data set. And when we look at what Alberta Health has provided in their substance use surveillance reports, that 2495 is remarkably close to the number of people that they had on reported as receiving methadone and buprenorphine naloxone in the first quarter of 2020. It's not an exact comparison, obviously, but we think we've got a good portion of the relevant patients in the data set. We did have 61 patients observed in the study die during the study period, and 87% of those patients were interrupted at time of death. And so I wanted to give those numbers, bolsters the idea that OAT is protective and gives a sense of our study population. So we would stop following their OAT at the time of their death. And so in order to look at OAT for patients in Blackfoot Confederacy, we had asked Alberta Health for their First Nations identifiers, which we've used in other studies around emergency department care for First Nations people, and asked that the areas outlined in blue, if First Nations people had lived in these parts of southeastern Alberta in the last 20 years, they be flagged as a First Nations person who lived in areas associated with Blackfoot territory. Not saying that there would be different definitions of Blackfoot territory and what it would include, but for the purposes of our study, this is what we had settled on. So that gave 562 First Nations patients who'd lived in those areas, a little more in the Calgary zone than in the South zone, but making up 22.5% of all the patients in the study. So a high percentage of the patients. I don't know, Dustin, if you'd like to comment there.
Yeah, I just thought 22.5% was a compelling number when we have so many numbers of Indigenous people. But I look at these numbers in 562, that means that 562 of our First Nations clients, including Blackfoot members, were accessing treatment. This is treatment, right? So I find it compelling that they're taking their own initiatives and things like that in order to move forward with their lives, because it's been shown that the research says, it stabilizes lives. It does these kind of things. So even during the time of COVID, they were still attempting to, press on and persevere through their sobriety. So I just wanted to say a little mention about that.
Dustin. And so in terms of those patients, there was some differences between the First Nations patients and the overall. So 58% of the First Nations patients were female compared to 35% of the other patients receiving OAT in the Calgary and South zones. 35% lived in the South zone compared to just 3% of other patients. 51% lived in the city of Calgary compared to 85% of other patients. And over to Dustin.
Yeah, and a compelling number there is 58% of First Nation patients who were female. And this is really remarkable to me because that shows that women are kind of leading the charge in their therapeutic lives. and it's something that we can kind of look at and say. Also, at the time, Subutex and Suboxone and these kind of things were used for females that were in utero pregnancy. So they weren't using heroin on the streets. The thought was that we would replace it with these, because these Subutex and these kind of things, Suboxone, are less birth defects in women that are pregnant. And, this also might be a reason to skew the data if possible. I don't know. But I still find it compelling that the females are leading the charge. So.
And so then looking at our main outcome of patients experiencing interruptions in our study periods. So 88% of the First Nations patients who lived in the selected areas experienced at least one interruption during the study period. That's compared to 78% of other patients on OAT in Calgary and South Zone. And we didn't want to leave it at that. So with Rhonda's group, we had run logistic regression models to see if we control for various factors in demographics and where people are accessing the healthcare system. What do we see in terms of odds of experiencing an interruption? And so age, so for every 10 years of age someone has, their odds of experiencing an interruption in treatment comes down. So older people having fewer interruptions. Then I've got a rectangle here around the First Nations people who'd lived in those areas we selected as associated with Blackfoot territory. So we're really striking 2.65 odds ratio of experiencing the interruption when you're controlling for these other factors like age and sex. Female compared to male, we didn't see a difference in interruptions that was statistically significant. Emergency department visits, disappointing for me as an emergency department researcher. The more emergency department visits a person had per month that they were observed for our study, the higher the odds that they would have an interruption. I said it's disappointing because emergency departments can provide OAT and re-engage people in treatment, but it may be reflective of overall health and social needs, bringing people to the emergency department and leading to more interruptions. And then we did look at hospitalizations. That didn't come out significantly. And looking at the COVID-19 period versus the pre-COVID period. Now, it looks like there are higher odds of interruptions in the COVID period, but I do want to talk about that. So we think that there are more long-term OAT patients in our pre-COVID period. And because the longer someone is on OAT, the more used to having the medication in their life they are, the less likely they're going to have interruptions. So we did run a sensitivity analysis. We said, well, what if we take out all the people who had an OAT prescription in the first couple of weeks of our study period? And the odds ratio actually then flipped over, and it looked like the people who were initiated during COVID had the lower odds of having an interruption. And so we really weren't able to say, did COVID-19 for our study data set cause greater interruptions? But we looked at the COVID-19 period as an interaction variable. And when we do that, we see that for the First Nations patients who lived in those selected areas, in both periods, before and after the COVID period begins, there's the higher odds of First Nations people having an interruption. And then we did modeling around the number of interruptions people would have for the months that we were observing them in the study. So the median number overall was 2 interruptions. 50% of patients had 2 interruptions. But 25% of First Nations people who had the most interruptions had 4 or more. The 25% of other residents of Calgary and South Zone who had interruptions had 3 or more. And then when we put this in models and control for other factors, we say First Nations people who lived in the selected areas had 0.34 more interruptions per month that they were observed compared to other residents of Calgary and South Zones. Now, obviously, you can't have 0.34 of an interruption. You have one interruption or two interruptions. So if you translated that into other terms, you could say it would take 3 months for a First Nations person to have an interruption compared to other residents who wouldn't have an interruption in that 3 months. And we looked at, because different medications have different retention reported in the literature, so the literature suggests that methadone is a bit better for retaining patients in treatment. So we were curious, well, what medications were patients receiving? So in the pink here, 63% of First Nations patients in the selected areas received only buprenorphine naloxone, and that's compared to 49% of other patients. So there's a difference here that First Nations people are more often receiving buprenorphine naloxone. Just 12% of First Nations patients identified for the study received prescription for methadone alone, compared to 19.7% of other patients in the study. And then also a little bit smaller number of First Nations patients received a mix of medications or some other medications we'd included, like morphine. So digging a little bit deeper into this, we looked at, well, what percent of patients had interruptions on each medication in each period? So we've got the pre-COVID period, so that March 15th to September 30th, 2019, compared to the COVID period, the same period in 2020, the two medications. And the First Nations patients identified are in blue, other patients in orange. We haven't run statistical significance testing around this. We don't want to find a lot of false positive statistical significance, but what I think is compelling is that in all cases, on each medication in each period, there's a higher percentage of First Nations patients who experienced an interruption in treatment. And every interruption, we know, is a chance to have a bad outcome, to use substances that are unregulated, of unknown quality, and have an overdose event. And then we looked at how many days of medication were patients receiving at a time. So you can have a prescription, say, for 30 days of medication, but it might say dispensed every 2 days or dispensed every 4 days. So how many days dispensed were patients getting at a time? So this graph, we've got the pre-COVID period and the COVID period again, but we're now looking at interrupted patients and patients who aren't interrupted. And we're interested in that because patients who are having interruptions, maybe their provider will think they need a little bit more support, or they need a little bit more engagement with their healthcare providers, may provide them fewer days dispensed at a time. There may be concerns about diversion of the medication. So we're now showing how many days on average did patients get at a time. First Nations patients in the selected areas in blue, other patients in orange. So interestingly, the patients without interruptions are getting longer prescriptions. And everyone's prescriptions are longer in the COVID period. People are getting more days dispensed at a time in COVID. So providers are saying, okay, we're all isolating. We're not meant to be having contact with each other. So to control the spread of this virus, people were getting more days dispensed at a time in the COVID period. But then again, what's really striking is the fewer days dispensed for the First Nations patients compared to the other patients in the Calgary zone. And so if having to come into the pharmacy is a burden to pick up your medication, it involves travel and exposing yourself to other people, we think this may relate to the higher number of interruptions that we saw for the First Nations patients. Now, other OAT medications, and the main one is methadone, the prescriptions are quite short. The days dispensed at a time, I mean to say, is quite short. Most were for just 1 day. But we did run the averages. And again, here we see fewer days dispensed at a time for the First Nations patients compared to other patients in the zones on average. So now to go into our discussion of the findings. We can't clearly determine whether COVID-19 was increasing interruptions in the study population we had for our data. Ontario research, and there's been a couple of studies now, suggests that COVID-19 didn't increase OAT discontinuation, and the authors argued that that was because longer take-home doses helped protect against interruption. And we did see those longer take-home doses in our study data set. And then in relation to other studies, there haven't been a lot of studies on First Nations interruptions in OAT. But research from Ontario by Holton et al. Does show that First Nations patients have shorter times to discontinuation of OAT, which they defined as greater than 14 days without OAT, than the general population. And so similar to the findings we've had in our study. I'm gonna turn it over to Dustin.
Yeah, and we always find it compelling that, well, why are they receiving less doses? You know, and these are the questions that we have to ask. Is this racism? Is this stereotyping? Is this, because we all know that the interruptions are what's going to cause fatalities with, opioids especially. But we also have to be mindful of like methadone, if they were polysubstance abusers, like with also using alcohol. It's one of those things that it can be fatal, and so there may be some of those concerns in there, but it's all been proven that culturally grounded Indigenous-led OAT programs are more successful and they have better retention. And it improves trust and all these kind of different things that go along with it. And I really like the strides that the Kainai or the Bloods, whatever you want to call them there, they're delivering these things right to homes, and trying to prevent interruptions, because we've known that these interruptions are going to have people having withdrawal symptoms and lots of things, comorbidities, I guess we call them, and but by improving these cultural programmings for reasons, we've found that it's beneficial, and I think that's remarkable, and we should also be really paying attention to that, Indigenous-led kind of things, therapies, and even in OAT. I think another number that might be manipulated a little bit there is like I said, there's no detox centers on reserves and things like that. There weren't at the time of the study. And sometimes methadone is dispensed only in a tea that they have to show up and drink daily. And so maybe those had some factors that prevented, longer prescriptions. And the idea of our people being blocked or held back or underprescribed or any of these kind of things is compelling to me, because there's even though the odds are not exponentially huge, they're still greater, and it has to be mentioned. So that's that.
This is a concern, so that there has been a national literature review by Russell et al. Looking at what are the guidelines for take-home doses, and it tends to rely on ideas of stability, but that can be variously defined. Sometimes it's called social stability or emotional stability or mental health stability, housing stability. So what Russell et al. Found was that this idea of stability for take-home dosing is really left provider discretion. So this will lead to a lot of variability between providers, but also a lot of opportunity for bias to creep in. And so in other work Pam Roach has done, some of our work on emergency care, anti-Indigenous racism is well documented among Alberta physicians. And so we wonder if these shorter take-home doses could be in part due to the effects of anti-Indigenous bias, as Dustin was saying. We did meet with the Blackfoot Nation and Tribal Council health staff, and there was discussion of other potential factors which would impact OAT continuity. I'll turn that over to you, Dustin.
Yeah, and one thing that we're still finding is this being tethered to a primary care provider. Sometimes the I don't know what's the problem now, but even in our communities now, we're dealing with people not staying tethered with their primary care provider and things like that, and that relationship, that trust and relationship and things like that goes on there, is maybe we're missing something there. And as of course we have these social determinants of health too, that as impoverished people living in impoverished communities, non-insured health benefits and other things like that, so we're only under Indigenous health and not being able to access all points of care. And that's more of problems with interactions with colonial systems, right? And as we look at it, we just have to figure out which social determinants and things like that moving forward that we can help alleviate. And like as I mentioned out at the Bloods, they kind of thought about one and are delivering it into the homes and things like that. So I know that's a bit above and beyond, but it's still a pertinent information for the data set.
We have a number of limitations in the study. Results reflect First Nations patients living in selected areas, which we defined with the Confederacy as related to Blackfoot territory, but this isn't an analysis strictly of Blackfoot members' outcomes or of First Nations outcomes. We didn't have any data on housing, so we couldn't control for housing and its effect on OAT. And the COVID-19 emergency shelters did provide OAT, and so we don't have any data on dosing that occurred in those shelters. We didn't have data on polysubstance use, which can impact OAT, as Dustin was saying. Now some people wouldn't consider this a limitation of our study, but I kind of think it's worth mentioning. We didn't interview patients and providers to get the qualitative context around this administrative data study that we conducted. So our conclusions: the interruptions in OAT were very common, both before COVID and during COVID. The First Nations patients who lived in selected areas had a greater odds of interruptions when controlling for other factors and a greater frequencies of interruptions compared to other patients. The fewer days dispensed among the identified First Nations patients might have contributed to that reduced continuity in care. And we believe there's room for future research looking at equitable prescribing medications. And just invite you, Dustin, to make any closing comments.
Yeah, and as we see the conclusions that we see here, it's troubling to me as a health director. These are my people, and interruptions in OAT were common, and that shouldn't be part of the equation at all in all this, right? And just because of where they live, they have greater odds of interruption and things like that. That shouldn't be part of it either. So when we're talking about these kind of things, it's about a paradigm shift, if you will, in our OAT delivery systems, either through the pharmacy or our healthcare providers, our primary care physicians, and things like that, to keep that continuity of care going. And I hope moving forward, we could examine equitable prescribing and equitable access to not only healthcare centers, but pharmacy centers and things like that. Because the numbers were still compelling before COVID, and because we had the numbers from before and after. So they were still being, ostracized a bit. And for prescribing, and this turns into a trust or a stereotyping type things, or just downright racism. So these numbers need to be looked at a bit more, because my people's lives are at risk.
Thank you, Dustin.
Thank you both so much. I assume that's your concluding slide, Patrick. Okay. And yeah, I have several questions. Anyone here who has any questions, please type them into the Q&A or the chat so we can make sure we get to them. I'm curious, and I know I'm part of the team, so the fact that I'm asking Patrick questions now is he might have words with me later, but that's a lot of interruptions. Does literature show that that's sort of normal levels of interruptions? Does this establish what can be expected on OAT? Or does Calgary and the South Zone have a high percentage of interruptions to begin with, even before you account for the higher interruptions for First Nations people?
Yeah, one of our team members asked the same question recently. So we're working to pull those numbers and put them into our paper. But my understanding of the literature is that yes, interruptions are just incredibly common with OAT.
Why was 6 days considered an interruption? What was that based on?
And so we'd just gone back to prior studies that had looked at that and defined it that way. So it's enough time that the person may then be seeking out alternate forms of opioids, and we know from the literature that an interruption creates a discontinuation. People use similar terms in different time periods for that. But kind of looking at the same thing creates a high chance of an overdose. And then the Ontario study I mentioned, they did look at like, well, these are people like, are they actually tapering off and going off? They're not on treatment, and they found in their study that was really uncommon. Most of the stoppages they observed didn't show any evidence that it was managed medically. It was just a stoppage, and I would expect that. Yeah, so that's what the Ontario literature shows. It raises questions: would Alberta be the same?
Well, and that draws to one of my other questions, which was how did the Ontario study sort of account for the difference between long-term patients and shorter-term patients? Because you highlighted that was something you saw in your data that threw the analysis off.
Yeah, and the best way to do that would be to look at patients who are on treatment before the period that you're interested in, and take those patients out of your data set on a go forward basis. And that's not something that we had done in our study, and hadn't wanted to go back to our who provided the data set to us for a new data pull, just given the already lengthy timelines to get to some results.
But did Ontario do that then?
Now I'd have to go back and look at those particular studies. I think in most epidemiological studies, that's how people would handle that.
Okay. And then the other question that popped into my head was, if you think that the long-term patients difference impacted the number of interruptions, do you think it could have impacted some of the other statistics, like the ED visits or other things that you saw that you analyzed for?
Yeah, and so I didn't show the full model for that. We could certainly look at it afterwards, but it looked like the impacts of other things were pretty well the same when we took out those long-term patients. The one that actually flipped over and went to the other side, so the odds ratio changed direction, was the COVID period.
Okay. So my final question, and I'm still waiting for other people to jump in here. Dustin, you mentioned some like delivery of the drugs and culturally connected programs having better outcomes. So I guess, would you like to speak to more about what you'd like to see? I was thinking, particularly here in Calgary, which is where I'm located, do you know of, I guess, programs like that, or the ability to connect patients to programs like that?
Yeah, absolutely. I can echo a few that are out there, like closer to home. Even the drop-in centers and things like that there in Calgary are trying to add an Indigenous component to it to make it a safer space for our
Mhm.
Indigenous populations. And I think that's what this really gets down to. When we get down to ER visits, it's terribly abrasive and it's inconvenient for everybody across the
Mhm.
board, right? But when we start getting into discussions about Indigenous populations, there's lots of things that deter them, which is trauma that they've endured, residential schools, trauma with the healthcare systems and things like that and injuries. Like a lot of these opioid addicted people they didn't get there on their own, right? They had a bad leg break or something like this, and were given opioids right across the board. So I think that responsible prescribing is something else too, and providing more options as in the lines of physical therapy and occupational therapy with cultural components in there. I think this is more compelling for us to explore a bit more as opposed to just domineering with Western medical practices that have been shown to be left wanting.
Mhm. Mhm. Okay. Well, thank you. Denise, do you see? Oh, I do see something. Um, so a question from one of the attendees is that they're curious how recent reconciliation and Indigenous health initiatives changed the barriers to accessing opioid agonist therapy for First Nations peoples. So I guess they might be asking, has anything recently improved access? Well, we would hope they improved access. They don't imply that it's an improved one. They said changed barriers.
Yeah.
So yeah.
Well, and I think by the nations, particularly the Blackfoot. I can speak to the Blackfoot. Uh, like we just had a new detox center open in Pikunii, in Brockett, Alberta, and we just had a new treatment center open in Again. These kind of moves are what's going to really, we believe in, especially on our on-reserve clients, but we don't want to forget about our urban Indigenous clients either. Our because they're kind of left blowing in the wind. A lot of the grants that we write for are all for reservation populations and all these kind of different things. But what we're really making a move for at the Confederacy, because we're housed out of Calgary as well, is that some of my main marching orders for what I do is to be considerate of the urban population. So we're trying to come up with ways that are soft handoffs and things like that from health centers in supporting clients that are taking the initiative to improve their own lives and take control of their health. So we're doing lots of initiatives on what that looks like for our part, but I don't think the racism has gotten any better, right? And so I don't know how to remedy any of that because that's on the powers that be, not particularly the Indigenous populations. They're just going in to see the doc and, these barriers that exist from personal bias and how they were raised, whatever that looks like, it always plays into the Indigenous healthcare experience.
Absolutely. And is seemingly very hard to battle against. So um, I know Patrick's leading some work in that also within AHS. Um, but that doesn't create the right environment rapidly. That's that is for sure.
I think just um, so we looked at a particular point in time for a particular area, but we did figure out how using the um, pharmacy data we're privileged to have provincially, ways you can look granularly at days dispensed to different populations. And so if a group that had access to their identifiers, whether it's the federal banned list or in another way, wanted to look at this contemporarily, they could do so.
That's good to know. And they could probably contact you for help getting started on that, or at least advice on who to contact.
Yeah, and I think so. I think we'd want to be sharing the way we we sorted things out. There's lots of long meetings with investigators and calendars and going through, okay, so if it's like this and then they're in hospital and then this, is that an interruption? And so, yeah, I'm happy to share, I think.
I know you said you didn't survey people, but I do know that you did do a lot of work talking about the choices you made with the analysis to make sure that it was reasonable and made sense to everyone. Yeah. Okay. I don't see any other questions. So I'll give about 30 seconds in case someone's madly typing right now. But I would like to thank everyone for attending the CRISM addiction rounds. We've canceled the June session, so please do join us in September for the next series of webinars. And please do complete the post survey. This was the first year of these rounds, and we're hoping that they've been educational and helpful. And we'd love feedback on what we can do to make sure they work for everyone. And again, thank you, Patrick and Dustin, for coming and presenting this this study to us. I think it was good work, even though we weren't able to anticipate all of the challenges with the analysis. But there was definitely a lot more to work with. And with that, I will let everyone go a couple minutes early before your 1 o'clock meetings. So thank you again.